today. I've mentioned we're waiting that we are recording the session. So if you don't want to be seen on the recording, which we will put on our website for people unable to attend, then please do turn your cameras off. We are really pleased to be joined today by Joe Matthews from the Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board. Joe is the Senior Urgent and Emergency Care Lead for Bucks Place, and he is talking to us about preparing for winter in Bucks, which we have been joking in the team this morning. We're very on message with the snow today. So welcome, Joe. You're going to give a presentation and then we will take questions from participants.
Can I just interrupt, Zoe? My name's
Sure.
Diane.
Hi, Diane.
Like I've got two people waiting in the waiting room. I'm not sure whether that's been cleared or not, but it'd be horrible if somebody was waiting and couldn't access this.
We will look into that, Diane. Thank you.
Okay.
I think we've got Fiona and Becky
Sorry to interrupt.
having a look. Okay, no problem. Thank you. Joe, are you okay to start?
I am, if everyone's happy. Can I just say apologies for the technical issues. It looks like there were some updates. My laptop wanted to install at 12 o'clock and it wasn't willing to delay them any further. It's an absolute pleasure to be here. And Zoe, thank you for that introduction as well. So yeah, to confirm, my name's Joe. I work for the Buckinghamshire Urgent Emergency Care Team as part of Buckinghamshire Place. And we sit within Buckinghamshire, Oxfordshire, Berkshire West Integrated Care Board. I'm going to share some slides now, and I'm going to do my best to talk through them. Zoe, obviously, if hands go up and you want me to address them, I'm happy to stop at your instruction and take those questions. I have made a commitment as well, everybody. I know there may still be a few acronyms on these slides, so I will try and address those sequentially. I know acronyms definitely don't help when we're trying to go through public-facing presentations. Obviously, within the NHS, we're a little bit too reliant on them, I think, at times. And I'll make sure I break those down so that they're properly explained. I think I had the pleasure of doing this last year as well. So I do have a little bit of experience in this, but I'm just very, very keen to talk through these at pace. Within this slide deck, we will cover a couple of key things around the winter plan. So the first thing, probably the most important thing, is the lessons learnt from last year, which would be winter 23-24. For the purposes of this presentation and for everyone's understanding, we are currently in winter 24-25 as per the national designation. We will also cover the winter interventions and the escalation pathways that we have in place for this year. Hopefully, I'll be able to demonstrate that based on some of the lessons learned from last year, we've tweaked a few things. We've also recognised where things have worked well. We've kept those in our plan for this year. If it's very much a mantra, if it's not broken, no need to fix it. We'll also talk about some of the risks and challenges anticipated for this winter period. Zoe, as per your introduction, with the weather this morning when I was out walking the dog at sort of 7:15 in the sleet and the snow, it felt very apt that I'd be here today to talk about winter. We are reminded when the weather changes like it has done today, just what winter can feel like for us out there. And we'll also talk through some of the forecast in terms of the data that we can use to try and give us some insight into the future and what we think is going to happen over winter and the anticipated demands on our services. As usual, with the Buckinghamshire Winter Plan, it was a multidisciplinary, multi-agency effort to pull bits and pieces contained within this document together. And in terms of how the plan is delivered and how we monitor our own performance against the plan, it's myself and my team that will be responsible for doing so. I'll move now, if that's okay, onto the lessons learned section. That is the next section. So across Buckinghamshire, we developed the winter plan to support 5 identified key challenges from across the whole of Buckinghamshire. The winter period was evaluated from last year to ensure lessons could be learned, and through that process for the winter of 23-24, we found that overall, whilst activity increased, and so at Stoke Mandeville, for example, and Wycombe Urgent Treatment Centre, where we saw all of our overall attendances increased by 7.6%. This was seen across the system and wasn't just sort of consolidated at Stoke Mandeville. And on average, there was a 12% reduction from the previous winter. So when we look back and sort of reflect, 22-23 presented a lot more of a challenge to us in terms of the volumes of patients attending our emergency departments and urgent treatment centres than last year did. There were two drivers, I think, that we were confident to identify within this. The first one was it was a less severe winter in terms of respiratory viruses and flu. I don't know if there might be a bit of a consensus on this presentation now, but I think certainly my memories from winter last year were that we didn't see sort of the cold weather patterns that we've already seen today in Buckinghamshire. It felt quite mild. I remember, Christmas Day, for example, anecdotally, it was around sort of 13-14 degrees, which, it was mild. And that did impact the fact that I don't think we saw quite the spread of respiratory viruses, flu, and also we understand that COVID is still knocking around there as well. People were just a little bit warmer. The second thing was, our work that we're all doing across the system to improve the alternatives to ED, so emergency departments, is starting to impact, as exhibited by the increase in the use of a couple of different things that we have going into a wide range of services. So we have an application that our primary care physicians, our general practitioners use, as well as our ambulance paramedics use. It's a digital application that allows them to see what services are open and available to them when they're treating a patient, either in a GP surgery setting or in the patient's own home. And we did see last year, and I will sort of show some of the data around that, but that we were able to push a lot of activity that would have come to our emergency departments and our urgent treatment centres into other teams that were better equipped to manage patients and also able to support them as well in their own home, which is obviously a real bonus, especially when you think around sort of the Christmas, New Year period. The last thing you want to do is see a relative or loved one admitted into a hospital setting. We know how challenging that can be, and we've really put a lot of time and energy into developing our services in Buckinghamshire that can actually help treat people in the community, which it's a national it's on the national wish list, if you like, for NHS England. They want to see more of this, but we know that factually it's based on actually better outcomes for patients. We can say that over 80% of winter actions last year were completed by Bucks system partners prior to the commencement of the winter period, which was good. So we put in, all of the services and the changes and the pathways that we needed to in time for winter to start, and that definitely helped as well. I'll move on to the next slide. I'll just give this a little bit of focus as well on the screen. Appreciate people may not be, I'm lucky I'm working off two screens today, but I know that some people are working off one screen on a laptop. So appreciate graphs aren't always easy to review, but I will talk to them. So you should be able to see my cursor more or less. The graph on the right, this highlights the attendances to the Stoke Mandeville Emergency Department across winter 23-24. I pulled this data myself and I started the graph around the 30th of October. And you can see here we're averaging sort of around that 350, 400 patients. And that stayed sort of steady really across right up until Christmas Day when we saw the drop. And that's a normal drop. We would always see that and expect that around Christmas Day. Having had the benefit of working in a hospital on Christmas Day on more than one occasion, it's traditionally a quieter day, Boxing Day too, and then we do see things really pick up in the second half of winter, which I always look at from January onwards. So we started to see a little bit of an increase and then a big increase towards the end of March, and that may sort of stagger a few people, but that is quite a usual pattern of activity. So there was nothing untoward there. But it gives you an idea of sort of the daily numbers that were being managed by Buckinghamshire NHS Trust in that emergency department. The graph down here on the left, this tracks the percentage performance. So you'll read about this a lot in the newspapers. We like to talk about all types of performance, and that's set against a patient arriving in A&E and being either signposted for discharge or admission within the first 4 hours. So if you think from the point of your arrival, within 4 hours, we want that A&E department to know what it is we're dealing with and what we're doing with that individual. Are we bringing you in for an admission into one of our medical or surgical beds, or are we looking to discharge you home into the community with follow-up? And you can see that, we were in and around sort of the 70% mark. Just to set some context for this year, NHS England wants NHS trusts to be achieving 78% as a minimum baseline. And that is the trajectory that's set up until March 2025, the end of. So, we've got a bit of work to do. Based on last year, though, we were doing quite well with our acute trust. Buckinghamshire NHS Trust were doing really well. We were hitting around sort of 76, 78%. And as we got through into March, we hit the 80% on a few occasions. So we were really happy with that performance. It was set against obviously less attendances at that emergency department from the year 22-23 from that winter, but still it was positive. So we were happy. We felt that the mitigations and the planning we put in place had helped, certainly in terms of that front door performance. It sounds quite selfish, but from an urgent emergency care perspective, when NHS England are talking to us and are asking us what are we doing, and they're scrutinising performance within our locality, because of the nature of the work that my team does, we are worried about what's happening primarily in terms of the emergency department. That's notwithstanding the fact that we do have a broader remit that extends a little bit further than just what happens at an emergency department. We pulled a little sort of activity graph together as well, just to sort of highlight, I guess, the differences between the two winters. As I said, I'll try and zoom this in a little bit just to make this a bit easier to read. But this red box that I've marked out shows the weekly attendances at Stoke Mandeville for 22-23. And you can see how the data does shift around. It is an SPC chart, so a statistical process control chart. But you can see these blue dots representing the data point. And then you can see, as we are here in winter 22-23, and then we compare it to winter last year, it had changed a little bit. You can see it's dropped down slightly, those data points. So we know that from an emergency department perspective, we weren't as busy, but other services that we set up had obviously captured some of that activity that would have otherwise come to that front door. In terms of 111, I know everybody on the call will be familiar in broad terms with the 111 service offer. Again, it's a national priority. It's not something that we can opt out of. We have to deliver it across the nation. But for this year alone, starting in January 2024, we've just been keeping an eye on the call volumes and the total calls that needed to be triaged through 111. As I think people may be familiar, I mean, look, I myself have on at least one occasion in my time had to use 111 to access healthcare support. So I know it's a service that, it's not straightforward. You call up, you go through a triage process. They may offer a call back. You're then sat waiting by the phone. But, we're respecting the fact that I think in Buckinghamshire, we do see good utilisation of our 111 services. But what we've noticed through this year, carrying on until September, and I will be updating this graph as we go through. We're currently waiting for the full set of October data from the 111 provider. But you can see that on a month-to-month basis, we were going from around sort of 22,000 calls in January this year, and we dropped down to around 17,500 calls by September. So over the course of this year alone, we've seen 111 activity just dropping off slightly. That is an anticipation, though, that as we now move through October, November, December, and again, Anecdotally, my colleagues from the 111 service are telling me they are seeing the increased number of calls now, and we will be plotting that data as we go through winter. But they are starting to see now that increase. So we do expect by January 2025, which is only a couple of months away, that this graph will start to head back up, probably to around the 19,000 to 21,000 mark. That's what we're anticipating anyway. And we'll be monitoring right up until March 2025 to make sure that 111 is managing its activity in an appropriate way. I did say, obviously, one of the areas that we would cover would obviously be the winter interventions escalation. So this is where we sort of get into the nitty gritty, some of the specific detail around what we've got in place to help us this winter. The next slide, there's a number of points that I just want to talk to. So I'll work through them sequentially on my slide, but obviously if any hands do go up, Zoe, please pause me, and I'm happy to talk to them in more detail. I will try and zoom this in as well. Again, I'm aware it's not easy working off one screen. So for this year, one of the first things we wanted to do ahead of winter was to develop and fully integrate a single point of contact for the frailty hospital at home and urgent community response teams to enable seamless pathways for patients to receive the right care first time. So this single point of contact.
Sorry, yeah, Joe, can I just interrupt? Yeah. So I'm just not sure people will know what hospital at home is. That's all. Yeah, sorry.
I should go. I think that's a valid point, Zoe. I'm going to go through that now. So in terms of those two services, hospital at home, this is our local offer. It's a clinical team run by the NHS Trust, but they manage patients at home in the community. So wherever that patient's community setting is, the hospital at home team will be able to do visits as required to ensure that medication and any other therapeutics that are being delivered are being managed and maintained appropriately. They'll also be able to take bloods and do other forms of health monitoring to make sure that the patient is on that recovery journey. And the urgent community response team is a rapid response service that can get out to a patient in the community within 2 hours. Quite often, the urgent community response team will receive their referrals from the ambulance service, where the ambulance service has attended and has deemed that they don't need to bring the patient into hospital. However, there is still an element of illness that will require some management, and they can pass over to the urgent community response team, who are better geared to come out to the patient and ensure that treatment and well-being can be maintained in their own environment, which in quite a few cases and quite often with certain phenotypes of presentation, straightforward chest infections, for example, that's a lot better than bringing somebody into hospital where it can be a little bit more complicated and convoluted in terms of delivering that treatment. Also acknowledging that hospital can present a greater risk in terms of infection and other issues around sort of isolating somebody rather than actually keeping them where they might be better looked after by friends and family and better managed in their own environment. The single point of contact, it's not for me and it's not for yourselves to be able to contact, but that single point of contact is for clinicians, it's for general practitioners, it's for ambulance paramedics to use as a way of referring a patient into a service. And by doing this appropriately, that avoids the individual patient being brought in for a hospital attendance and potentially an admission. I don't know if anyone's had a chance to sort of go to Stoke Mandeville recently. I would hope for health reasons that you've all stayed away. But we do have a new ward which went up and running this month. It's an emergency medical receiving unit. We've used capital funding to help establish this. It was much needed capacity. We're offering circa 20 beds as part of this new unit. And this new unit helps take patients out of the emergency department onto short stay pathways where perhaps we're looking to turn the patient around and be able to discharge them after, a day or two's worth of treatment. It already we've seen the statistical benefit in terms of how Stoke Mandeville currently, as we're dealing with the winter pressures and the numbers of attendances coming through, has been able to manage its own workload and not clog up its own ED department, emergency department, because they haven't had places to move patients to. So already we're seeing that benefit. This isn't temporary capacity, this is permanent capacity, and it's here to stay. And it's much needed in terms of, it's well overdue, I think, in terms of the investment into that, into Bucks NHS Trust sort of hospital system, and it is working really well. The next point I'll cover, expanded emergency surgical bed capacity. So there's a really big piece of work being done at the moment, and there is still elements of this work that are ongoing, but the surgical care group are delivering it, and they're delivering it at pace. So we have our surgical assessment unit, which is open 24/7 as part of the emergency floor. It's there for those surgical patients. There's a bit of a work being done to expand that capacity at the moment, and some of the wards are being changed around to be able to accommodate more patients, so more surgery, more trauma and orthopedic patients, for example. We know through winter that's where that pressure is going to be. And the offer of the surgical assessment unit is going to be formally rebranded as a same-day emergency surgery unit. So patients attending with a surgical issue can not only expect to be seen, but can also be expect to have the surgery done. Obviously, it's patient dependent, but on the same day. And that's going to be absolutely crucial for us as we go through winter. The next point, and Zoe, I did see a question just pop up in the chat there. Do you want me to address it?
So can I just give you a time prompt, Joe, as well, because we're due to finish at 12:45. So I'm just mindful so that people have questions, as we can ask questions as well. The question was from Hills: do we have stats on how long people are kept on hospital corridors?
It's a good question. We do have statistics. We do capture the data for any patient that's kept in corridor care. It's not something I'm prepared in this particular presentation or at this particular moment to share, but it is something that is monitored nationally. If there was a directive, I guess, from the NHS regional team, it may be something that we could share with Healthwatch at a later date. I would suggest that what we could do is come back and do a winter mop-up presentation, if Zoe and the team agree, and we could present some of that data at the end of winter to show how we've limited or possibly even nullified the use of corridor care, because a lot of these actions and interventions are there to prevent us going into corridor care. But absolutely, we could probably cover that at a later date. In terms of the other interventions as well, so we're developing a new integrated front door team at Stoke Mandeville to bring community services into the emergency department. So that's services such as district nursing, rapid response, obviously adult social care have a presence there already, housing as well, and that's to make sure that any patients that we can turn around from the emergency department do get turned around, and that we don't unnecessarily admit people for social reasons. The electronic discharge processes and command centre, so that's in place. We have a new control centre, if you like, for Buckinghamshire NHS Trust, where the beds are managed from, and that's up and running now and working quite well. Olympic Lodge, so you maybe recall this from the previous winter presentations, but that's our immediate close by step down capacity. We opened that last week, and we're working towards getting to around 30 beds. We're currently today aiming to fill 20 beds there, and that's using the existing hotel suite capacity at Olympic Lodge as part of the Paralympic Stadium development, which sits just behind the hospital. So it's very much within arm's reach for us, and we can use that to move any delayed transfers of care. So anybody who's stuck waiting for a service that hasn't quite kicked in yet, and they're safe to do so, Bucks NHS Trust have that area staffed, and we can move patients across via patient transport service and put them into Olympic Lodge and look after them there whilst we chase up whether it's a package of care or something else that they may be waiting. We're also working towards the implementation of a new model for our discharges for patients going home with packages of care. So something that has happened in Buckinghamshire over a number of years is a couple of different services have been commissioned at different times to provide what is broadly the same service. What we're doing now is working with those main three constituent parts. So our Home First team, our home intervention team, and our rapid response service, to bring all the good work that they're doing together under one team, which makes a lot more sense in terms of governance, financial management, and delivering, what is going to be an equitable service for all patients. There'll be no differential between those three offers. They'll all be part of the same offer going forward. Again, as well, it's probably worth highlighting, we've got our virtual ward capacity. So when I spoke about hospital at home, that is the virtual ward offer. By the time we get to January, end of January 2025, we hope to have enough capacity to be able to treat up to 160 patients per day in their own home, which is a staggering amount. And we're not done there. We do expect to be able to expand that capacity even further as 2025 goes on. But for every patient that we're treating in the hospital at home virtual ward setting, that's one less patient that's been admitted to hospital, which is absolutely fantastic. And it's brilliant. The more people we can treat at home, the happier those individuals are going to be. I know I don't want to be stuck in hospital. That's certainly a fact. Just to pick up a few other things as well, the vaccination program, we went early with that. So we rolled that out in September, and with the new respiratory virus vaccine rollouts as well. So hopefully you've all had an opportunity, if eligible, to have your flu and COVID jabs. You've been able to access those through pharmacy, primary care. We went quite early with that in Buckinghamshire, making sure that pharmacies were reaching out to people, and the primary care clinicians, the general practices, were texting their patients to say, you're eligible and please come on in. I think that probably covers really the bulk of the interventions. If we're thinking about time, Zoe, what I will do is I'll just move on if there's no other questions at the moment, just to highlight a few bits and pieces around the hospital at home or virtual ward offer, if that's okay. Were there any other questions at the moment?
just for a couple of minutes, if that's okay, so that we can then so that we've got a little bit of time for questions. Is that okay?
Of course.
Thanks.
To make the hospital at home offer a little bit clearer and just what we're trying to do around that, you will see when you read papers, pick up on news articles, virtual wards is the name of the NHS initiative. What we do locally is we call that hospital at home. That's the badge we've given it. And the main things are around, obviously, the bigger the service and the value of the service is really, we can avoid more hospital admissions, support early discharges as well. So if you think about a patient that may be stuck on a medical or a surgical ward, and they really want to go home and we can continue their treatment at home, then that's what we can do. We are reducing the pressures on the emergency department, which obviously make the headlines, as emergency departments often do if they come under significant pressure. It's one of the most popular points of the NHS to sort of be covered by media, but it's also one of the points that we want to really address. I can see that question came in. So a virtual ward is effectively a collection of patients.
Oh, no, sorry, that was just me putting a link to an NHS
Thank
thing.
you,
What
Zoe.
it is, sorry.
We'll move on. And obviously, we know that the outcomes are better for patients when we can treat them in their own home. It can be a much safer way of delivering the same care that we would be doing in hospital. But imagine you've got the benefit of being in your own bed, in your own environment, and you know where all your bits of equipment, you know where your food is, you know how to move around. It's really not easy if you wake up at 2 a.m. and you're being treated for an infection in hospital and you're trying to make it to the bathroom and it's just not a surrounding that you're familiar with. We know, generally speaking, we can do things much safer in your own environment. Currently, the service, we are working towards an 8-to-8 delivery service, and that's where we're at the moment. We are at 140 beds, but that will be up to 160 beds by the end of January. And those beds, obviously, that's virtual. So that's virtual capacity. That's capacity for up to 140 patients a day at the moment. And obviously, we'll have that up to 160, which is a massive offer. And we're going to keep growing that service because the demand is definitely there. And again, most of our referrals will come from, GPs, the ambulance service as well. But also, we can take referrals from the emergency department directly, as well as the acute wards, so medical and surgical, and the frailty team as well. And again, it's a hybrid model. There'll be face-to-face contacts involved for any patient who's treated under that service, but there's also virtual contacts as well. So telephone calls, text messaging, etc., to make sure that everything's on track. And it's a brilliant service. What I will do, I'll just cover off, I think, adult social care as well. So adult social care sets off a number of objectives. I always feel a little bit fortunate talking about the good work that they're doing, because they do so much of it themselves and link in with us really, really well. But they set out a number of objectives in terms of being able to deliver safe and effective care this winter. They're really, really concerned about making sure that the vulnerable residents in Buckinghamshire are well looked after. And they're really keen as well to make sure that they utilise all of that good support available from the voluntary sector, Red Cross, Age UK, and other groups as well. And within that, they've committed to a number of things. So they're very much involved in our hospital discharge. So we have a number of social workers involved with our integrated discharge team. So they're based at Stoke Mandeville. There's also some at Amersham Hospital and Wickham Hospital as well. And they make sure that all of the referrals and all the patients that need to be seen as part of a social care assessment are done so in very quick time, often responding to same-day referrals, which is fantastic. As well, they're continuing to do all of their work around delivering those extra services that we talked about. So when I spoke about some of the teams that offer packages of care within the patient's own environment, so whether it's the Home First offer, the Home Independence Team offer, the Rapid Response offer, adult social care are very much involved with all of those three offers of support in the patient's own environment to make sure that the right support is delivered and that support is tapered down and taken away when it's been successful in rehabilitating the individual in their own environment. They've also done a lot of work with commissioning this year. So there's been a lot of work done with Age UK and Red Cross to make sure that there's been extra support commissioned so that we can get those voluntary sectors and those voluntary sector organisations engaged and supporting our Buckinghamshire residents where necessary. So being able to take people out to support patient transport, get them to and from appointments, take the most vulnerable and the most immobile out for those urgent trips to pharmacies, general practitioners, whether it's a shopping trip as well, whether it's supporting, the completion of paperwork, it could be supporting with bills and other applications as well. We've got all that voluntary sector support there. So it's been really good. We've had some good work for adult social care in and around this. What I will cover off as well, I think it's quite important.
I think, Joe, I'm really sorry, but we haven't got long left. So if you don't mind, are we able to share some of these slides after the things? Is that okay? And would you be able to take some questions now?
Yeah, I'm happy to take questions now. I don't see any reason why we can't share the slides. I'll get them converted to PDF format and sent out. But I'm happy to take questions now. Apologies for being
That's okay.
On a little bit.
Thank you. I appreciate that you've stood in at short notice as well for Caroline. So thank you for that. So I've got a comment saying that you're talking about it, you're coming at it from an NHS performance perspective. But what can you say about the patient experience? What's that going to be like this winter?
It's a good question. So I think there's always two things here. It's very easy for us, I think, to look at it specifically through a performance lens, because we are used to, with our services that we currently provide, being judged not exclusively but largely on performance. And those metrics, they're not arbitrary, but they are set nationally, and they don't always link to patient experience. I think it's very, very, very sort of important to note, treating somebody quickly within a 4-hour target doesn't necessarily mean that the experience is going to be great. We've spent a lot of time in Buckinghamshire with our individual providers making sure that their patient experience teams are linked in with our winter plan and with our service offers, so that we can ensure that we monitor that patient experience. I think, crucially, the patient experience is going to be very, very good this winter, because I think with the support offer that we've got, we're going to avoid lots of unnecessary admissions to hospital. And I think, generally speaking, what we see is the more patients we can treat in the community and in their own environment, the better the feedback is. And we really reserve those admissions for the sickest patients when there is no other alternative. So I'm confident we're going to have a good patient experience this winter.
Thanks, Joe. Has anyone got... I've got another question in the chat, but has anybody else got any questions before I go to that? Because I think that's Mike again, isn't it, Mike? We'll go to Hills next, and then we'll go back to yours, Mike. Hills, you're on mute at the moment.
Yeah, with regards to the volunteering, as a PPG, we were looking at helping out with volunteering with patient prescriptions and stuff like that, and patient transport, but we were told that there is a problem with the patient transport with insurance and various other things. Is there some is there something that you've got that you can give us to show us what we can and can't do?
That's a great question, Hills. To hand, there's nothing I've got that I can give you which will give you guidance about what you can and can't get involved in terms of a patient partnership group and supporting your fellow patients and constituents. But I can go and get that information for you. We do have some guidance, I think, from the ICB that could be available in terms of voluntary sector and how we support individuals. We can also make sure that we get you some of that guidance out to say, actually, rather than you as a PPG picking up the work, here are the numbers to call to get the voluntary sector that's currently commissioned to come and do some of that work for you in terms of making sure your fellow patients can get to their GP appointments, making sure people have access to shopping, assisted shopping services, etc. So I'd be happy to, through Zoe and the team, to get some of that information back and distribute it to the PPGs across Buckinghamshire, because I think that's very important information to have. But thank you for any efforts you are trying to make on behalf of other people.
Okay, thank you.
Thank you. So a second part to Mike's question. So will there be any publicity aimed at patients to explain what they should expect? For example, virtual wards and how to navigate the system as quickly as possible?
Yeah, Mike, that's a great question. So I think this is one of the things we always struggle with, I think, in the NHS, is getting that comms out and really explaining what is available. There's a comms strategy that is in place from the ICB. I don't have line of sight of it purely because they are working as a different directorate, but the comms team for the ICB are presently, and I know they've been doing some work on it this week, they are linking in with the providers, so Bucks NHS Trust, Oxford Health as mental health team, and other providers as well, to work out a strategy of getting the message out about the different services that are on offer and all the regular sort of advice and guidance about what to do if you feel unwell, what services are available, when should you be calling your GP, when's it best to go to 111, can you turn up to your urgent treatment centre unannounced, and what hours are they going to be open, etc. So yeah, there is something that will be coming out. They'll be using all of the usual comms sort of relay channels. So not much of it is radio or television based. A lot of it is down to social media now. But they'll also be making sure this information goes out to primary care so that it gives GP partners an opportunity to put the same information up on their own websites. I know my GP practice is good at publishing some of the ICB material, and also we'll be using the NHS app where possible as well to get that little bit of messaging out to patients to say this is what's open at this particular time. But I think it's definitely something Mike will take back again and again and again, is I do think we can do a lot better on the comms piece as an ICB, and I think we'd all accept that.
So what did you say the time?
The general theme you might.
Sorry, Mike. Carry on.
So the general theme, Joe, you might have spotted from my two questions, is that it all seems to be a bit inward focused about meeting NHS targets and so on. And hand in hand with developing your winter plan, it would be good if you consulted PPGs, if you put out some draft information, if you sort of encompassed the community rather than just sort of delivered a plan and told us whether it was meeting your targets or not.
I think that's fair, Mike. I think it's definitely something we'll have to take back for next year as well, because if we accept that we're delivering in winter now, I think we need to probably do a different approach next year and work more closely with yourself and other PPG representatives, maybe to make sure that what we're producing, we're also producing a very clear comms plan, and we're delivering that message to the patients so that you all know what you can access and when, and what those services provide. I do think that's absolutely fair.
Well, I look forward to change.
Jenny? You're muted, Jenny.
Oh.
There you go.
Yes, sorry. Yes, communications again, but I just think if we could tell the stories through the patients who are benefiting, if you can capture some good stories and share them more widely, not just the data and what's available, but it's what a difference it's making to people. And you may not have them at the moment, but for next year's comms, I think it's really important to do it in a different way. And you know, I'm fed up as a sort of Healthwatch advocate, having comments from people, including many of my own friends, about grumbling about GP appointments and hospital appointments and the dates. They only know, you know, they can only see it from a very narrow lens, and there's so much going on. And I just think the system ought to be much better at telling the good news and reassuring people that things are really moving in the right direction. But we can't get that message from this sort of presentation. I mean, it's a brilliant presentation and well done on everything that's going on, but how do we tell everybody else out there? And even perhaps using the regular communication that goes out from Martin Tett as leader of, you know, the council. I mean, that could be used in a very much more powerful way, and it reaches so many houses and families in Bucks. So yes, I mean, I know you're onto it, but I think it needs to be escalated and moved on quickly.
Fabulous question, Jenny. And I think this is the point, and this is where I probably will actually, honestly, I will accept actually that there is a responsibility here myself, specifically with those patient stories, because regardless of what the ICB comms team does, the examples of patient stories is actually something that I can do. It's a separate stream of work, but I have been working with colleagues on telling a couple of stories about our same-day emergency care unit at Stoke Mandeville, which is an alternative to ED. I've had the good fortune actually of accompanying my own dad through that unit twice after GP referral, and he was treated really successfully for two types of presentation that traditionally would have necessitated 2 or 3 days in hospital. Instead, he got to go in for a couple of hours, go home, come back the next day, and then be discharged completely from the service. And he himself fully admitted that at the age of 68, he was much happier doing that than spending even one night overnight in a hospital where you can't sleep because the lights are on and there's lots of noise. So Jenny, I think actually it's probably, this presentation is coming up with a couple of actions for me, actions that I've already sort of mentioned in terms of the questions that Hills and Mike, for example, have put through. But in terms of your question as well, there probably is an action there to actually come back to another Healthwatch meeting sooner rather than later, to maybe talk about a couple of patient stories and show what has worked well, and also not be afraid to maybe point out a couple of stories, maybe things didn't go so well, and we can look at how that could be presented, because it would be remiss of me to sort of claim that it works really well all the time, because again, it comes back to Mike's point about patient experience. I think you know, it's not going to be the same for everybody, but we are aiming for a high standard. So yeah, I think again, there's actions I can pick up here that we can follow up with another time.
Thank you, Joe. I do think we need to bring it to a close now, and because we are running out of time. If people do we run out of time. And apologies that we've given you extra work for you stood in for Caroline. Now you're coming away with actions, but thank you. We do really appreciate you standing in at short notice. I think because we started slightly late, and I just think that if anyone has any questions that they weren't able to raise today, are you okay to send them to Fiona? I think you've got Fiona's email, and we will try to get them answered by Joe or someone at the ICB. Is that okay with you, Joe, as well?
Absolutely.
Yeah.
I do think we've got this opportunity to move forward with Healthwatch and Bucks, especially with the changes that have gone on with the ICB. We're in a stable platform now. I think, you know, we should engage a little bit more. So I think that's something we can commit to over the next couple of months, no doubt. That's
great. Thank you very much, and thank you all for coming and for your questions. As I say, if you have questions that you weren't able to ask, please do send them through to us. We will. Part of the reason I'm ending it now is because poor Fiona has to now go away and do the transcription for this film, and it takes quite a long time. So if it goes on for much longer, she'll have a busy couple of weeks. So thank you, everybody, and thank you, Jo, for coming. We do appreciate it. Thank you. Bye bye, everybody. Thank you.